Good afternoon. It's a difficult time after lunch to give a lecture, but I think that it'll be sufficiently entertaining so that you can survive this. We are going to talk about cardiac amyloidosis. Both Drs. Bitola and Dr. Sonam presented it as one of the new applications of nuclear cardiology, and we are just going to delve into some aspects right now by refining the literature on this topic. We are going to start with a clinical case quite recently. It was a patient, 65 years old, without any cardiopathy cases before. He had hypertension and he had progressive dyspnea, and he was therefore admitted to the hospital. The dielectrum showed a 66, a complete blocking of the right branch and a partial blocking of the left branch, some diffuse obstructions, and there wasn't many voltage, which is the importance of the diagnosis of many voltages. He had a Doppler echo that showed a severe thickening of the walls of the left ventricle and a global contractibility in the anterior wall, a flexion of 40 to 45%, a diastolic dysfunction, a severe one, with a general pattern of hypertrophic. We can see the ventricular cavity, the periodontal thickness, and the increase of both atriums. We had conducted a cardiac MRI thinking about of an infiltration disease of the myocardium, and we had an RT sequence and impossibility of annulment of the myocardium in different inversion times, which was compatible with cardiac amyloidosis. So we also had a score of 12, which is a quantitative result of MRI in relation to the amyloid of the ventricular wall, the enhancement of the ventricular wall. So this patient had a high level of amyloidosis, but the doctor thought that it was not relevant for this clinical case, and he wanted to disregard a historical component with a MIDI with dipyridamole. And the study showed, as you can see here, what seems to be a thickening of the walls as if it was an but he also had an ejection fraction that was a bit descending, so there was no evidence of ischemia either. So since it was about a man older than 60 years and cardiac insufficiency with diastolic function that was pretty much preserved, and with a blocking of the right branch and the anterior left branch, and also an MRI, a late MRI in the right ventricle that led to a strong suspicion of cardiac amyloidosis, and we conducted SPECT with this patient. So there was an uptake of biventricular diffuse intense uptake, and we did gate it, which means that this was like conducting a perfusion study, a triggered perfusion study. So it was pretty much the ejection fraction of the MIDI was the same, and Perugenia 3 score, we're going to talk about this, and heart thoracic index against the lateral of 187, which was cardiac amyloidosis. So what is this about? When we see this, amyloidosis is considered to be a multisystemic disease, and it's relatively rare, but not so much as we thought. caused by extracellular deposits of protein in several tissues and organs, which is a protein that suffers a normal folding, and that's why it cannot go through the normal function, and it's deposited in some organs. We don't know the reason for this, but for example, in myocardium, there are some types of proteins that have a special affinity, as we can see for the brain. There are other proteins with special affinity, and this leads to this disease. Every time amyloidosis causes a high morbidity rate, in general it's because of a cardiac affectation. It could also be because of renal impacts, but cardiac affectation are the most severe ones, and this happens especially in the primary amyloidosis because the AL and the deposits of trans protein and retina and ATTR. It could be non-mutant or savage or spontaneous. It's called savage because it appears naturally, or hereditary because of a genetic mutation, which is the ATRM. As we can see, the letters are A for amyloidosis, then we have the type of protein, L, which is light chain, TTR is transretina, and then we have the subtype, right? WT, wild type, or M because of mutant. The heart can participate in amyloidosis of type A, ischemic amyloidosis type A, and other rare acquirements. And the non-mutant is a very common finding in person older than 75 years. It could be more than 30% or 20, 30 or more than 30% in autopsies of patients older than 75 years old, even if they didn't have any cardiac symptoms or cardiac dysfunction. Or disorder. So clinically, when can we suspect this? As we said, he's a male person older than 65 years old with a restrictive cardiac insufficiency. He has this dizziness, periorbital purple echinosis, macular patches, a syndrome of the carpal tunnel, and microglossia. Some of them, all or maybe none of them, of these symptoms and signs could be present. But if they are highly suggestive of amyloidosis, especially systemic, and some of them with cardiac participation. As we can see, why are we interested about the epidemiology of amyloidosis in Latin America? If we take what we believe to be a 10 cases per every million inhabitants, 10 cases per every million inhabitants, we believe that it's the general incidence of amyloidosis as a disease. We can see that we could have, according to the population in our countries, all these cases per year. In Brazil, more than 20,000, in Colombia, more than 5,000, Argentina, 4. So in general, in Latin America, we have almost 40,000 cases per year of amyloidosis. So how many of these actually affect the heart? We don't really know.
There are a lot of cases of systemic amyloidosis without cardiac affectation or non-significant affectation, and there are cases of cardiac amyloidosis without participation of other organs. Therefore, it's very hard to find out the prevalence, and there are several cases that we know are subdiagnosed. Coming back to the types, the ones affecting the heart the most, as we said, were the light chain, which affects the heart greatly, the M, due to the mutant, it's hereditary, and the white type, which is cardiosystemic. We have the degree of cardiac affectation, 50% in AL. In the mutant hereditary, it varies according to the mutation. And in the wild type or senile, we have 100% cardiac affliction. The interesting thing is, as we were saying, is that the one that used to be called senile is apparently behaves like Alzheimer's disease. For some reason, it begins to deposit amyloids in the heart, beta amyloids, and as you study patients that are older, the prevalence increases. The same happens with ATTR in the heart of these patients. These are some of the images from histopathology. We will not stop here. And some differential characteristics. As we were saying, the prevalence is known for the white type, but it's much more frequent than initially thought. What else would be interesting? It's predominantly male. That's very typical. It comes along with carpal tunnel syndrome. There are breakages in the brachial biceps, which suggests ATTR wild type. There's mutation also that could also occur. The type of alterations in the EKG, the low voltage in the QRS is characteristic of this. There can be a pattern of pseudoinfarction. There can be moderate to severe hypertrophy. And FEV can be preserved, but in more advanced stages, it can be diminished because when the thickness of the cavity increases, the end of diastole volume tends to decrease due to the impossibility of having a complete diastole. Therefore, there's a formula for the diastole volume. The end of diastole decreases and the ejection fraction falls. The important thing is that it's not a hyposystolic insufficiency, but instead it's restrictive. We're going to see this now. Pyrophosphate and DPD, the degree of uptake is different, but basically we have very similar characteristics in all ATTR types compared to light chain ones. And this is something we talked about before. See that the TTR protein is segregated by two organs, the liver and the corvoid plexia. This is not only to produce cephalorachidal liquid, but it's also seen that it produces TTR. It produces this protein. You can see the wrong deposit of the protein and the treatment according to what we want to attack. If we want to diminish the production, then we can recur to two methods, either liver transplant, which is going to produce a young protein, to call it that way, with no possibility of a normal folding, or medication called genetic silencers, which counteract on the phenotype that produces the folding of the protein. We can stabilize TTR through physical, chemical processes that impede folding, or once we have the deposit generated, we can resort to drugs that are being tested for Alzheimer's, which clean the amyloid from the tissue. So this is very important because all these therapeutic measures are used for TTR amyloidosis. So it's very important that we are able to distinguish between the subtypes of amyloidosis and see that this is also related to the prognosis of the patient with amyloidosis. Cardiac amyloidosis, familial mutating cardiac amyloidosis, and light chain amyloidosis have been studied in this research, and it was seen that the survival rate was much better in TTR than AL. AL is engaged with a worse and ominous process. It has a 50% mortality rate at 6 months, the light chain, and ATTR has a survival rate that is higher. The gold standard would be biopsy, non-invasive methods, as we were saying, the EKG, echo-Doppler, RMI, pro-BNP, protein, highly sensitive troponin, and the nuclear medicine specters that are going to occupy us now. We were talking about the EKG. This is something that we saw. The EKG has a positive predictive value that is very important. This is from two works, one from 1982 and the other one is from 2014, which coincide in calling electrocardiographic changes as something very specific for amyloidosis, but sensitivity may be overestimated in this case. The echocardiogram is very characteristic in terms of the appearance of smoked glass. And here we have the strain, the longitudinal strain, which is something the modern echo-Doppler. You can see the normal polar map of the strain, and in cardiac amyloidosis, you can see that this strain is altered. It's only conserved in the apex, and in an early one, you can see the evolution where there is an alteration, an intermediate alteration of the longitudinal strain. The MRI shows late enhancement. There's an interstitial spacing, and there is a quick washing of the normal tissue and the vascular pool, which improves contrast with infiltrated tissue, so it has a very high predictive value. Here we have other parameters for magnetic resonance, which would enable a certain degree of confidence. But we wanted to talk about the radio pharma and those for PET scans, and within those, the radiopharma products, we would have pyrophosphates, DPD, the MDP, and HDP. In our countries, the most popular one would be MDP. I don't know if in Colombia it's widely used. MDP is the radiopharmaceutical of choice for bone imaging. DPD is widely used in Europe, and HDP is widely used also. As Dr. Salmon was saying, this is nothing new. The uptake of phosphates in amyloidosis, here's a work from 1982, but there are some earlier ones showing some diagnostic considerations about cardiomyopathy. At that time, there were no subtype known people would say that someone would have an amyloidosis and that was it. There were no measures but beyond contention, but there was no other possibility for treatment. Nowadays, we have something, but see that there are several works from that time where in the 80s it was quite common to have a scintigraphy, and we would say the patient has amyloidosis, maybe so, maybe not, and that was the end of it, because if the patient was asymptomatic, then there was no other advancement made in the diagnosis. But it was used in acute infarction. And when we had a pattern with acute infarction, we would say it's a massive infarction. And those patients would have amyloids more commonly. But the truth is that this is nothing new. And the topic with knowledge of the different subtypes, the topic has been retaken, and not absolute quantification, but relative quantification in order to reach the subtype diagnosis. This represents an opportunity for us because it's a new application. It's very easy and very cost effective. It has a very high impact in patient management, and it's easy to interpret. See how from the visual point of view, Perugini in 2005 established 4 categories, 0, 1, 2, and 3, according to the cardiac uptake and the relation with bone uptake in the case of pyrophosphate. So 0 and 1 would be absent or mild uptake, moderate would be 2, and severe would be 3, more than the bone, and the doses. Its dose is highly specific for ATTR amyloidosis. However, we need to mention that the AL type generally uptakes pyrophosphate very mildly, but it can be incorporated in an advanced stage. So what Dr. Soman was saying, that it's important to have serum studies for light chains, because if there is a light chain, then this is not ATTR, despite the fact that it is capturing the myocardium. MDP is a bad tracer for amyloidosis. Unfortunately, it's the most widely used for bones, but it's a bad tracer for ATTR amyloidosis and also for AL. There's a certain degree of uptake which is not specific. And why do we know that it's not specific? Because if we wait 8 hours, if we wait at 3 and 8 hours post-injection, you see that there is some uptake at the myocardial area after 3 hours, but in a later image that uptake is erased. This means that it's non-specific and does not correspond to amyloidosis because uptake in amyloidosis is maintained. There is no washing. We can quantify this as well in relation to the counterlateral, and we have this relation and it's higher than 1.5. Myocardial uptake is highly specific for ATTR. This study by Castaño is very complete. He had a 1.6 cutoff in quantification, and he saw that there was a probability of survival that was very different when the uptake relation went above or below 1.6. The prognosis is much worse if the uptake of pyrophosphates is higher. When to take these images? With scintigraphy, with bone scintigraphy, we take images at 2.5 hours, 3 hours, 4 hours after the injection. But we have found that sensitivity and specificity of pyrophosphate for ATTR is different according to the moment with the image is taken. See that when we take it 1 hour later, then we have a 95 sensitivity and 79 specificity. If we take it at 3 hours, sensitivity goes down to 58, but specificity goes up to 100. So some people propose taking early images, late images. Some propose taking images 2 hours later, which would be something intermediate. But we need to take this into account. It's the diagnostic performance is not the same for the images. This is in terms of visual score. Now, regarding the counterlateral heart relation, it happens that performance is better in early images compared to late ones. But in general, we could say that if we take images 2 hours later, then we have a good compromise between sensitivity and specificity. What wouldn't be the proper use of cardiac scintigraphy for the investigation of amyloidosis? These are recommendations from Gasnick, and it would be the following clinical scenarios. Patients with cardiac insufficiency, no aortic stenosis, no hypertension, no prolonged hypertension, patients who are older than 65 with cardiac insufficiency with no apparent cause, and with PV that is conserved or relatively conserved. Patients, mostly men, older men, with unknown neuropathy, bilateral carpal tunnel syndrome, arrhythmias, evaluation of cardiac affection in patients with familial amyloidosis that is suspected or confirmed, even if they are asymptomatic. ATTR variety diagnosis in patients with RMI that is suggestive of cardiac amyloidosis. This is where we would use pyrophosphates. Patients with suspected amyloidosis and counterindications for RMIs. Patients with pacemakers, with kidney insufficiency. These would be the proper criteria. Interestingly enough, there's an important role played in a group from France that is very recent, who researched cardiac denervation with MIBG as an early way to detect amyloidosis in patients with mutant amyloidosis, TTR. They had evidence of denervation in 60% of the patients, and 39% had biphosphonate uptake. Out of 31 asymptomatic people, DNG was abnormal in 30%. All asymptomatic people with DABG had a normal uptake of diphosphonates. Studies suggest that denervation occurs before the deposit of amyloid occurs. This is extremely interesting if we have this technique available. And what's at risk is the relation between the mediastinum and the heart. You know that when we research denervation, we have early and late images to see the washing. In amyloidosis, there is an early washing of the MIBG, and which is more altered is the later image. See the difference in survival rate according to the relation between the heart and the mediastinum. This is before and after the liver transplant, the MIBG uptake and the heart mediastinum relation. Finally, PET radiopharmaceuticals, carbon 11, florbetapir, with fluoride 18. All of these are markers, but they don't enable us to distinguish the type of amyloid. We're going to progress here pretty quickly. See that in this case, in TTR and light chains, there is a similar uptake. There is no distinction, so it has prognostic connotations as well as therapeutic ones. And well, out of the list of possibilities, the best chance we have in nuclear medicine for evaluating amyloidosis would be with phosphates, especially pyrophosphates and DPD. Forget MDP, it's not useful. And this is much more useful in applications more than PET radiopharmaceuticals. These are the technical conditions. You can find this in the guidelines and practice points. 2 hours post-injection. We can repeat 3 hours later if it's doubtful. Planar, thorax images. If we have the possibility to do it. And here we have a flow chart, a proposed flow chart. If we have a patient that, due to MRIs, has suspected cardiac amyloidosis, then we perform a tracer injection. We inject phosphates and we can find 0, 1, 2, 3 degree. If it's a degree 0, then it's very probable that it's an ATTR, that it's amyloidosis, and it's ATTR. If it's 2 or 3, it's pathognomonic, and we can have a genotyping and see the variables, the variants, if it's a wild type, or if it's genetic. And if it's grade 1, then we need to have histological confirmation and typing of the amyloid. See that, just to finish, you can see that from what we know, we see how the different parameters evolve to evaluate in amyloidosis. See that from the beginning, from the onset of the disease until death, we see that up until the middle and the type of evolution, then there is a deterioration in the symptoms of the patient. This comes along with ventricular dysfunction, and it's inversely proportional to the degree of myocardial infiltration, which follows an S-shaped curve, and the troponins that come later in the evolution. And we would have a unique opportunity, which would be the detection of amyloidosis, and typification of amyloidosis, perhaps before halfway through its evolution, and that would enable us to apply some therapeutic measures. And this is the last slide, which apparently shows that there could be a trigger for Desmond phosphorylation in acquired heart failure. According to experimental studies in lab animals who had an experimental model of overload, of pressure overload through the constriction of the aorta. They started to see that the animals actually had a progressive accumulation of amyloids that could be labeled with florbetapir. And against controls, maybe in order to see that there was no endothelial blockage. This means that perhaps these amyloid markers could be useful in the early detection of molecular changes in patients with heart failure, especially in terms of pressure